Welcome to the Funnel Effect. Today, we are undertaking a critical deep dive into a really game-changing technology in cardiovascular medicine. Cardiac optical coherence tomography. You'll often hear it called OCT.
Yeah, OCT, and it's this high-resolution imaging that has fundamentally rewritten how we understand heart disease and also how we actually do complex procedures.
We are focusing today on pretty definitive review. It synthesizes, over 2 decades of technical evolution and, clinical application.
That's right. We're drawing our insights primarily from the work of Taishi Onetsu, MD, PhD, and Ik-Kyung Jang, MD, PhD. Their review is titled Cardiac Optical Coherence Tomography, History, Current Status, and Perspective, and it was published just recently in JCC Asia, so very current information.
Exactly. And for you, the learner, our mission today is to give you a rapid but thorough synthesis of this whole field. We're going to trace the entire journey, from an early MIT invention and these bulky lab prototypes all the way to its current status as this indispensable optical biopsy tool. We want to understand not just what OCT is, but really how it's transformed both the research side and the real-world success rates of percutaneous coronary intervention, or PCI.
And it really boils down to resolution. That's the key word here. OCT gives physicians the power to visualize structures inside a living patient with almost microscopic detail. It's incredible. It provides a level of clarity that honestly you could previously only get by examining tissue samples in a pathology lab.
Right after the fact.
Exactly.
Yeah.
So this fundamentally shifts how we diagnose, how we size things, and how we optimize stent placement. It's a huge leap.
Okay, so let's start at the beginning. We're talking the early 1990s, the foundational science for OCT, optical coherence tomography, that was established by Professor Fujimoto at MIT back in 1992. But, taking it from a physics concept in a lab to a clinical cardiology tool that required a massive multidisciplinary effort. Right.
Oh, absolutely. It wasn't trivial. That big leap really happened when the Specialized Cardiac OCT Group was formally set up at Massachusetts General Hospital, MGH, around 1998. And this wasn't just, a standard clinical department. It was an active partnership.
Okay.
You had world-class scientists and engineers. The review specifically mentions pioneers like Brett Boma and Guillermo Turney working shoulder to shoulder with really forward-thinking cardiologists, including Dr. Ik-Kyung Jang, who, as we mentioned, is one of the authors of the review we're looking at.
That makes sense. That collaboration sounds crucial.
Yeah.
And I guess it was immediately put to the test, because before you can use any new imaging thing on a living person, you have to prove it works.
Yeah.
Right? Prove its fidelity.
You got it. They had to validate that what the machine was showing them actually matched up precisely with what pathologists were seeing under a real microscope.
So how do they do that?
Well, that validation phase was, you could argue, the most critical and, frankly, painstaking part of the whole process. The MGH team took on this, monumental task. They analyzed 357 human vessel specimens. Wow.
Yeah. Aortas, carotids, coronary arteries. Collected from 90 different cadavers. And they systematically compared the OCT images they took of these samples against the standard histology slides. The gold standard. And what did they find? How did that comparison turn out? Was it good enough?
By 2002, they had the confirmation they really needed. Their foundational work proved that OCT could accurately characterize the major types of atherosclerotic plaques. We're talking fibrous plaques, calcified ones, and those really important lipid-rich plaques.
Okay.
And the numbers, the metrics, they were undeniable. For example, for identifying lipid-rich plaques, they were getting sensitivities between 90 and 94%.
That's high.
Very high. And specificities were also excellent, ranging from 90 to 98%. So this proved pretty much unequivocally that the technology wasn't just giving sharper pictures, it was giving pathologically accurate data.
Which, that sets the stage for what sounds like one of the riskiest moments in the technology's history. The first in-man, or FEM procedure, this is around the year 2000.
That's right. And this anecdote, it really crystallizes the immense effort, the sheer difficulty involved in turning a lab invention into something you can actually use in the clinic.
Tell us about the hardware back then. It wasn't like today's machines, I gather.
Oh, not even close. The early hardware was, far from the streamlined consoles cardiologists use now. The prototype OCT console was described as cumbersome, thankfully, bulky, heavy, and extremely unstable.
Right.
Clinicians couldn't just, plug it in and hit go. They had to constantly monitor it, manually adjust parameters after literally every single image acquisition just to maintain clarity.
Wow. So you needed engineers right there.
You needed specialized engineering support right there next to the operating table. It was that hands-on.
And because of those stakes, the critical nature of it and all these logistical hurdles with the hardware, the thumb procedure actually happened overseas.
It did. Dr. Jang conducted it in collaboration with Doctors Seung-jung Park and Ki Bae-sung in Korea, and the sources really detail these extraordinary logistical challenges they faced.
Like what?
Well, first, you had dedicated staff flying ahead with this massive temperamental machine.
Okay.
Then, when they arrived, they found that critical components were actually damaged during transit. Broken.
Oh, no.
Yeah. So they needed an entire second team to fly in with replacement parts just to get the system operational for that first crucial patient.
The pressure must have been immense.
Unbelievable. You have to imagine that moment. The authors specifically note that if there had been a critical complication during that very first intracoronary procedure, it wouldn't just have harmed the patient, obviously, but it would have absolutely jeopardized the future of cardiac OCT as a clinical tool. Full stop.
Fortunately, they navigated all those risks successfully. That first imaging procedure in a living patient happened safely in 2000.
Yep, thankfully.
But that experience immediately highlighted the biggest roadblock to actually using it widely, right?
Yeah.
Which was speed.
That's the exact pivot. That problem drove the next decade or so of development. The first generation was called Time Domain OCT, or TDOCT. The first commercial system using TDOCT came out in 2004, got its CE mark in Europe. But it had this massive operational flaw.
Which was?
It was just slow, painfully slow. It captured images at only about 15 to 20 frames per second.
Okay, and why does speed matter so much inside a coronary artery? What's the physical issue there?
It's the blood. Simple as that. Blood is optically opaque. The light waves OCT uses just can't penetrate it effectively to see the vessel wall clearly.
Right, it blocks the view.
Completely. So with TDOCT, you had to perform proximal occlusion of blood flow.
Meaning stop the blood flow.
Yeah, the cardiologist had to temporarily stop blood flow using a dedicated balloon inflated upstream.
Okay.
And then while the flow was stopped, continuously infuse saline solution to physically clear the blood out of the way just to get a clean image.
Wow, how long did that take?
The whole process took about 30 seconds just to image a 50-millimeter segment.
That sounds
Yeah.
problematic.
It was. It was invasive. It carried higher risk. And critically, that physiological requirement having to block the flow, that's precisely why the US FDA held back approval for TDOCT. It was just too disruptive.
Okay, so the big leap forward was the transition from TDOCT to frequency domain OCT, or
Yeah.
FDOCT. This wasn't just a faster chip. It sounds like it was a fundamental shift in the physics that solved that blood flow problem.
That's exactly it. It was a fundamental shift. It gets a little technical, but it's clever. TDOCT worked by physically moving a reference mirror inside the machine to measure the light echoes sequentially. Think of it like using a single radar dish to map depth, point by point by point, slow.
Okay.
FDOCT, which came around 2006, uses something called spectral interference. So instead of physically moving a mirror back and forth, it measures the entire spectrum of light reflected back from the artery all at once, simultaneously.
Ah, so it's parallel processing in a way.
You'd think of it like that. It allows the system to calculate depth information for hundreds of points along the vessel wall at the exact same time.
And that simultaneous measurement, that's the game changer for speed.
Exactly. It dramatically increased the image acquisition speed, like orders of magnitude faster. So now, instead of 15-20 frames per second, the FDOCT system was fast enough to allow for non-occlusive imaging.
Meaning you don't need the balloon anymore.
Well, you still need a rapid saline flush to clear the blood momentarily because blood is still opaque. But because the image acquisition is so incredibly fast, the entire, say, 50-millimeter segment can be imaged in about 3 seconds. Just 3 seconds.
Wow, 30 seconds down to 3.
Huge difference. And that allows for much faster pullback speeds, like 20 millimeters per second. That efficiency, that safety profile, and that speed, that's what finally made OCT truly viable for the cath lab environment and, crucially, secured its US FDA approval in 2010.
Okay, and this technological leap, this speed, it leads us right to the core clinical question. Why do we need all this complexity when we already had intravascular ultrasound, or IVUS?
Right, the established tool.
Yeah, and this is where those superiority metrics, especially resolution, really come into play.
Resolution. That is the absolute key differentiator. OCT provides an incredibly fine spatial resolution. We're talking 10 to 20 micrometers.
10 to 20 micrometers. How does that compare to IVUS?
It's nearly 10 times higher resolution than IVUS. IVUS typically operates in a much wider range, around 120 to 200 micrometers.
10 times. That difference is just astonishing. It really is like switching from, I don't know, a standard definition TV to ultra-high def 4K or even 8K.
It's a good analogy.
And that massive increase in detail, that's why the sources keep calling OCT an optical biopsy, right?
That term is definitely earned, because OCT can resolve structures that IVUS simply, well, it smears them together, they're just blurry. OCT is far superior at visualizing the absolutely critical fine structures, things like the actual thickness of the fibrous cap covering a plaque.
Which is key for rupture risk.
Exactly. Also, detailed characterization of the lipid core inside the plaque, and even spotting microaccumulations of inflammatory cells like macrophages. IVUS just cannot resolve these really high-risk microfeatures.
But, as always in medical imaging, there's usually a trade-off. If OCT is a super high-powered microscope, does it mean it can only see the surface layer? Is there a depth limitation?
That's correct. That is the trade-off. Penetration depth. IVUS is more like the wide-angle lens, maybe. It provides greater tissue penetration, roughly 8 millimeters deep,
Okay.
which is crucial for assessing the entire vessel wall thickness and looking at, global vascular remodeling outside the immediate lumen.
So seeing the bigger picture.
Right. OCT's light energy just doesn't penetrate that far. Its depth is only about 1 to 2 millimeters. So for those deeper insights into the overall vessel structure, IVUS is still necessary. But for the fine details near the lumen, which is where most plaque instability actually happens, OCT is the undisputed superior tool.
Okay, so the technology gets approved in the US by 2010. The resolution's amazing.
Huh.
Yet the sources highlight this kind of surprising reality.
Yeah.
Adoption was actually pretty slow for a while.
Yeah, it was.
In 2014, OCT use was minimal. What was it? Only 0.3% of PCI procedures in the US and 1.3% in Europe. That seems really low. Why the hesitation to adopt such a powerful tool?
Yeah, it does seem low in retrospect. The reluctance seems to have been largely institutional and also guideline-driven. The established guidelines back then, the 2011 XESKI guidelines, they mentioned OCT, sure, but they didn't grant it any specific, strong clinical recommendations for routine use.
Oh.
IVUS, on the other hand, had already secured a pretty robust Class DA recommendation for complex cases and optimizing stents. And cardiologists, when they're making high-stakes decisions, they tend to adhere pretty closely to established guidelines, which meant they often defaulted to IVUS or even just angiography alone.
But the sources point out a really critical regional exception that kind of proves the potential, right? Asia, specifically Japan.
Yes, the Japanese experience is a fantastic case study. It really shows how regulatory policy and reimbursement can influence adoption. In Japan, their national guidelines gave Class I recommendations the highest level for using intravascular imaging for stent optimization, and specifically included OCT. And crucially, it was reimbursed.
And that made a
A
difference.
huge difference. By that same year, 2014, OCT was already being used in 11.6% of PCI procedures in Japan.
Wow, compared to less than 1% elsewhere.
Exactly. And overall in Japan, something like 90% of PCI procedures utilize some form of intravascular imaging, mostly IVUS and OCT. It just demonstrated really clearly that when policy supports high-resolution imaging, clinicians will readily adopt it. They see the value.
Okay, so the big turning point then for broader global adoption finally came with that critical 2021 XESKI guideline update.
Yes, that update was absolutely essential. It consolidated previous recommendations and, importantly, formally recognized OCT as a legitimate alternative modality to IVUS for guiding complex PCI procedures and also for treating left main disease.
So it got put on equal footing, more or less.
Pretty much. While IVUS retained its high recommendation, this formal recognition gave OCT the sort of institutional endorsement it needed to become more of a standard routine tool in cath labs outside of Asia as well.
Okay, so let's move into the practical application then. How exactly does a cardiologist use OCT during a procedure? The sources talk about it being structured into 3 key phases for optimizing the stenting process.
That's right. These 3 phases of optimization are absolutely critical for ensuring the best possible long-term success of the stent. The first phase is vessel assessment. This happens before the intervention even begins.
Okay, pre-planning.
Exactly. OCT provides incredibly detailed information on the morphology, the shape and structure, and the composition of the plaque itself. What's it made of?
What specific information does OCT give you here that, say, just angiography would completely miss? And how does that info change the plan right away?
Oh, it reveals crucial details like
Yeah.
the extent and exact location of calcification. Is it superficial? Is it deep? How thick is it? And critically, it identifies the presence of thin cap fibrotheroma or TCFA. Remember those vulnerable plaques?
Right, the high-risk ones?
Yeah. The sources show that actually seeing TCFA presence before you even touch the lesion is independently associated with an increased risk of periprocedural myocardial infarction, a heart attack, during the procedure.
Wow. So knowing that changes your approach.
Absolutely. If
Yeah.
you see a thick, dense, heavily calcified plaque, you know right away you probably need to pre-treat it aggressively. Maybe use rotational atherectomy, like a tiny drill, to modify the plaque first.
Yeah.
But if you see TCFA, that really thin cap over a big lipid pool, you might opt for a much gentler strategy. Maybe avoid aggressive balloon expansion right near that vulnerable cap to minimize the risk of rupturing it.
Makes sense. Okay, phase 2 is vessel sizing.
Got
That
it.
sounds straightforward, but getting the dimensions exactly right is obviously fundamental.
It is absolutely fundamental. OCT provides incredibly precise quantitative measurements, numbers, for both the vessel size, the diameter, and the actual length of the lesion that needs stenting. This data lets the operator select the perfectly appropriate stent diameter and length. Getting that perfect fit is essential for preventing late complications like restenosis, where the artery narrows again, or stent thrombosis, a dangerous clot.
And poor sizing is a major cause of those problems.
A primary reason for long-term failure. OCT minimizes this risk with its high-resolution measurements. You're not guessing based on a blurry angiogram.
Got it. And then the final phase, stent optimization. This happens after the stent has been deployed. And this is where OCT's amazing resolution really pays off, right? Detecting tiny issues.
Yes, post-stenting, OCT is just unparalleled in detecting minor yet absolutely critical mechanical complications that you'd easily miss otherwise. It can spot subtle intimal dissection that's a small tear in the inner vessel, lining right at the edge of the stent.
Oh.
And it can definitively confirm stent malapposition. That's where the metal struts of the stent aren't perfectly flush against the vessel wall. There are little gaps.
Which can be bad long term.
Very bad. Prone to clot formation. And most importantly, OCT provides quantitative measurements of stent expansion. It tells you precisely if the stent has opened up enough and achieved its intended minimum area.
Okay, speaking of quantitative measurements, that minimum stent area, the MSA, you said it's the single most important predictor of long-term success. But the sources flag a really critical clinical nuance about the actual numbers, the thresholds.
They do, and this is a really important point of caution for any cardiologist who's transitioning from IVUS to OCT or using both. It turns out that OCT systematically underestimates the true lumen area compared to the established IVUS measurements
Underestimates by how much?
by approximately 10%.
Wait a minute. If OCT, the new gold standard for resolution, consistently reads 10% lower than IVUS, doesn't that create a risk? Couldn't operators end up oversizing stents or maybe doing unnecessary post-dilatation just because the number looks lower than what they were used to seeing with IVUS? How do the authors handle that clinical dilemma?
That is a great question, and it's something clinicians definitely grappled with. The authors emphasize that operators absolutely must use OCT-specific thresholds for success. These thresholds have to be derived from actual OCT outcome data, not just blindly applying the old IVUS numbers.
So there are different goalposts for OCT.
Exactly. For example, data from the big MGH OCT registry, which specifically accounted for this inherent underestimation, suggested that the best MSA cutoff threshold, derived specifically by OCT for predicting stent failure, was around 5.0 millimeters squared.
Okay, so a different number than IVUS might use.
Right. And the clinical justification is this. While you might, in theory, slightly err on the side of mild oversizing compared to what an IVUS measurement might have suggested for the same vessel, the benefit of achieving truly optimal mechanical apposition, making sure those struts are perfectly against the wall, which OCT can visualize perfectly, that benefit outweighs the small theoretical risk of slight oversizing.
I see. The mechanical certainty you get from OCT justifies using its own specific threshold.
Precisely. You know the stent is well deployed mechanically.
Okay, so beyond just the MSA number, what are the other sort of morphological predictors of failure that OCT specifically helps identify and potentially correct during that optimization phase?
Right, so if the MSA number looks good, you then look closely for 4 key morphological issues that OCT is great at spotting. The sources point to, first, irregular protrusion inside the stent. That means some tissue or plaque material has squeezed through the struts into the lumen after deployment.
Okay, like squeezing through a mesh.
Kind of like that, yeah. Second is edge dissection, that tear we mentioned at the very start or end of the stented segment. Third is it confirms stent malapposition, those gaps between strut and wall.
And the fourth.
Actually, those are the main three morphological predictors mentioned consistently: protrusion, edge dissection, and malapposition. If any of these are present, even with a good MSA, the procedure isn't really complete. You likely need further post-dilation, maybe with a specialized balloon or sometimes even another stent to fix it. And OCT is the only tool that gives you the confidence to go back in knowing exactly what you need to target.
This whole shift in practice, it has to be driven by solid clinical trial evidence, right? Let's touch on some of the key studies mentioned, starting with Illumion.
Right. Illumion was really important early on. It was an observational study, not randomized, but designed to quantify the real-world impact of just having the OCT data available during PCI. And the results were pretty stunning. It showed that OCT assessment actually changed the physician's entire strategy in 57% of cases before the PCI even started.
Wow, more than half the time, the plan changed just by looking with OCT first.
Exactly. Pre-procedure planning changed dramatically. And then after the stent was implanted in the optimization phase, OCT led to additional procedures like post-dilatation or putting in an extra stent in 27% of cases.
Meaning angiography alone was missing critical flaws in more than 1 in 4 procedures.
That's what it suggests, flaws that could lead to later problems.
Okay, so the next step was Illumion third. This was a randomized controlled trial pitting OCT head-to-head against IVUS and also just standard angio-guided PCI. What was the main finding there?
Illumion III was crucial because it established non-inferiority. That's a key regulatory and clinical concept. The study found that OCT-guided PCI yielded a similar mean minimal stent area, that key MSA metric, compared to IVUS-guided PCI. Both were significantly better than angio guidance alone.
So it proved OCT was basically just as good as IVUS for achieving that primary mechanical goal.
Exactly. It showed OCT was a fully viable, powerful alternative to the established IVUS gold standard. It provided that high-level randomized evidence needed to really secure its place in global guidelines.
And finally, the doctor's study. This one focused specifically on a higher-risk population, patients presenting with acute coronary syndromes, or ACS.
Yes, the doctor's study compared OCT-guided versus angio-guided PCI, but specifically in patients with NSTE ACS, that's non-ST elevation acute coronary syndrome, and they used a physiological endpoint. The fractional flow reserve, or FFR, value measured immediately after the PCI was completed.
And FFR basically measures how well blood flows through the stented segment, right? Higher is better.
Correct. FFR assesses the pressure drop across the lesion or stent. A value closer to 1.0 means almost normal flow. It's a measure of the physiological result of the mechanical fix.
So what did OCT guidance achieve in doctors?
The OCT-guided arm achieved significantly better FFR values right after the procedure. The average was 0.94 in the OCT group versus 0.92 in the angiography-guided group.
That seems like a small difference, 0.94 versus under 0.92. Is it meaningful?
It might seem small, but it was statistically significant. And physiologically, it is considered meaningful. It suggests a potential superiority of OCT over just relying on the angiogram, especially in these higher-risk ACS patients. It reinforces the idea that achieving better high-resolution mechanical optimization with OCT leads directly to better physiological outcomes, better blood flow.
Okay, now we shift gears a bit. We move from OCT as a tool in the cath lab for fixing things to its role in understanding the underlying vascular biology. For me, this shift from using OCT as just a repair tool to using it as a diagnostic tool, actually confirming pathology in vivo inside the patient, that seems like the most profound application of this whole technology.
I agree. This is truly revolutionary. Historically, our understanding of how acute coronary syndromes, ACS, actually happen, well, it was mostly limited to autopsy studies, looking at arteries after the patient had died.
Right, a retrospective snapshot.
Exactly. But now, with this optical biopsy capability of OCT, we can actually differentiate the underlying mechanism of the acute event in real time in a living patient having the heart attack.
And the key differentiation that OCT enables is separating plaque rupture from plaque erosion. What do those look like under the OCT microscope, and why does telling them apart matter so much?
They look quite different visually when you see the OCT images. Plaque rupture is the classic mechanism we learned about. It's characterized by a clearly disrupted, broken fibrous cap overlying a large lipid-rich core. You often see an actual cavity or defect in the plaque where it burst open.
Okay, the classic volcano eruption model.
Kinda, yeah. Plaque erosion, however, is different. It's characterized by an intact fibrous cap. The surface looks smooth, but there's a large intraluminal thrombus, a blood clot, sitting directly on top of that intact cap.
So no obvious break in the wall, just a clot forming on the surface.
Precisely. They are fundamentally different disease processes happening at the plaque level. One is a mechanical failure of the cap. The other seems more like a surface phenomenon triggering clotting.
And identifying plaque erosion, which OCT allows us to do confidently, has led to this potential paradigm shift in ACS treatment, thanks to the landmark erosion study you mentioned.
Yes, the erosion study really capitalized on this new diagnostic capability. They specifically enrolled patients whose culprit lesion, the one causing the ACS, was clearly defined by OCT as plaque erosion, and they investigated whether a conservative management strategy, specifically using intense antithrombotic therapy, blood thinners, without immediately placing a stent, could be effective for these patients.
What was the thinking behind that? Why might avoiding a stent work for erosion?
The rationale was that if erosion is primarily an inflammation-driven thrombotic event happening on an intact surface, maybe you don't need a mechanical scaffold, a stent. Maybe potent antithrombotic drugs could dissolve the clot and let the underlying surface heal without intervention.
And what did the erosion study find? Did it work?
The results were quite compelling. The study showed that in this specific subset of patients with OCT-defined erosion, the thrombus volume significantly decreased at the 1-month follow-up, even without stenting. The clot got smaller on its own with just medication.
Wow. So this suggests that for a potentially large chunk of ACS patients, maybe a third of cases are erosions, a non-interventional, purely medical treatment might be a viable, less invasive strategy.
That's the potential implication. Now, large-scale long-term validation is definitely still needed. This is not standard practice yet. But it's a massive conceptual leap forward, and it was enabled solely by the high resolution of OCT being able to reliably distinguish erosion from rupture.
Fascinating. Okay, moving beyond the acute event, OCT also seems to provide a kind of historical record of the patient's disease activity. It can see healed coronary plaque.
Yes, this is genuinely fascinating stuff. OCT can identify something called layered plaque. On the image, it appears as these distinct, often crescent-shaped layers near the lumen that have a different optical density, a different look compared to the surrounding tissue.
And these layers aren't acute problems. They're old.
Exactly. They're not acute ruptures. They represent sites of previous subclinical plaque destabilization, maybe small ruptures or small erosions that happened in the past but didn't actually cause clinical symptoms. The body just healed them naturally, endogenously, and they became integrated into the arterial wall as these visible layers.
So OCT is like an archaeological tool, digging through the layers of the patient's past micro-events in their arteries. Does knowing this history, seeing these healed plaques, have any prognostic value for the future? Does it predict anything?
It absolutely does. The evidence accumulating indicates that the presence of untreated healed coronary plaque is a significant marker of overall vascular instability in that patient. It's been associated with a higher risk of future adverse events, predominantly things like ischemia-driven revascularization needing another procedure down the road because of symptoms. It really reinforces this idea that atherosclerosis isn't just a slow linear buildup. It's a much more dynamic cycle of destabilization, thrombosis, clotting, and then subsequent healing over and over again. And OCT allows us to actually see that cycle playing out with unprecedented clarity.
That's powerful. Now, you mentioned calcification earlier as a challenge for stenting. The superior resolution of OCT has also led to a completely new way of classifying calcification, right? Going beyond what we knew from older autopsy studies.
Yes, calcification is often the bane of PCI procedures. It makes the vessel rigid, hard to dilate, hard to get good stent expansion. OCT's superiority in assessing the morphology, the detailed shape and location of calcium, allowed researchers to look specifically at the different forms of calcified culprit lesions in patients presenting with ACS. And based on these in vivo observations, they identified 3 distinct subtypes of calcified lesions causing trouble.
Okay, what are the 3 subtypes?
First, there are eruptive calcified nodules. These are basically chunks or nodules of calcium that have actually burst through the fibrous cap and are protruding directly into the lumen, into the blood flow. Very irregular.
Okay, sounds problematic.
Highly thrombogenic and mechanically very difficult to deal with. Second, and this is the majority subtype, are superficial calcific sheets. These are more like sheet-like plates of calcium lining the lumen, typically without a big eruption, just a hard layer under the surface.
Right.
And third, they identified calcified protrusions. These are nodules that are still covered by some smooth fibrous tissue, but they bulge into the lumen.
Why is knowing this distribution, these subtypes, important? If most of these superficial sheets, how does that actually impact what the cardiologist does during the procedure?
Well, this novel classification, which came about purely because OCT could see these details in vivo, is vital for planning the pre-stent preparation. How do you tackle this specific type of calcium? Eruptive nodules, as I said, are tough, but those common superficial sheets often require very pre-treatment to ensure you can actually expand the stent properly.
Okay, what kind of pretreatment?
Things like specialized balloons or maybe more aggressive atherectomy devices, orbital atherectomy or rotational atherectomy, those drills we mentioned to physically modify or break up that calcium sheet before the stent goes in.
Ah, so if you didn't use OCT, you might just try standard ballooning on one of these hard, rigid sheets.
And you'd likely fail to expand the stent adequately. You'd get underexpansion, which is a major predictor of long-term failure like restenosis or thrombosis. So the precise classification really dictates the specific mechanical tool you might need to get a good result.
Makes perfect sense. Okay, for decades, the sort of holy grail in cardiology research has been trying to identify the vulnerable plaque, the one that's going to cause a heart attack before it actually happens. OCT seems to have really accelerated this research focus.
It absolutely has. It provided the objective visual criteria that were needed for these kinds of risk stratification studies. Numerous studies now, pretty consistently, the review mentions names like CLIMA, Combine OCT FFR, and others have confirmed the hallmark features seen on OCT that predict future adverse events in non-culprit lesions.
Non-culprit, meaning plaques that weren't the cause of the initial problem,
Yeah.
but are just sitting there elsewhere in the coronary arteries.
Exactly. Plaques that haven't caused a problem yet but look dangerous. The ticking time bombs.
And what is the definitive OCT-defined recipe for future risk? What combination of features makes a plaque truly vulnerable?
It consistently comes down to a combination of two key factors seen together in the same plaque. First is the morphological feature, the thin cap fibrotheroma, TCFA, or sometimes just called a lipid-rich plaque. This represents the structurally weak point, that thin cap over the soft core.
Okay, the unstable structure.
Right. And second is the hemodynamic compromise, a small minimum lumen area, MLA. Basically, the artery is also significantly narrowed at that specific spot, typically defined as an MLA less than about 3.5 millimeters squared.
So it's the combination of a dangerous-looking structure and significant narrowing.
That's the potent recipe. When both those factors, TCF lipid-rich plaque, A&D, a small MLA, are present together in a non-culprit lesion, the studies show an extremely high hazard ratio for future lesion-specific adverse events. It really reinforces that dangerous structure plus significant flow limitation is the combination most likely to cause trouble down the road.
That sounds really promising for prediction. However, you rightly mentioned earlier, there's a critical caveat we need to keep in mind regarding the conclusions from these vulnerable plaque studies. We need to temper the excitement a bit.
We absolutely do. While these findings defining TCFA and small MLA as high-risk features are robust and reproducible, we have to be cautious about overinterpreting our current ability to definitively predict hard clinical endpoints for an individual patient based on a single plaque.
Why the caution?
Well, most of these studies used primary endpoints that were often driven by unplanned revascularization. That's considered a softer endpoint. It means the patient needed another stent put in later, maybe due to returning symptoms or a positive stress test.
Okay, not necessarily a heart attack or death related to that specific plaque.
Exactly. It wasn't always hard endpoints like outright myocardial infarction or sudden cardiac death originating from that specific plaque. The actual incidence of those heart events from any single non-culprit plaque is still relatively low. And remember, coronary thrombosis can happen through multiple mechanisms: rupture, erosion, calcified nodules. So predicting the future of one specific plaque remains extremely challenging today, despite OCT's power. We're not quite at Minority Report levels yet.
Understood? Important context. Finally, in this section on biological insights, OCT has provided crucial understanding about why stents sometimes fail late, years down the road.
Yeah.
It helped identify this new pathology called neotherosclerosis.
Yes, stents aren't always a permanent fix. They can fail long term, and OCT has been instrumental in helping us understand why. Neovascularosis is defined as the development of newly formed plaque, lipid-laden, or calcified neointima within the struts of a previously implanted stent.
So basically, atherosclerosis starts growing inside the stent itself.
That's exactly what it is. Plaque is forming within the neointimal tissue layer that grows over the stent struts over time. And OCT is the ideal imaging modality to see this because its high resolution can clearly visualize things like lipid core formation or calcification happening within that thin neointimal layer inside the stent. IVUS often can't resolve that detail.
And how does this concept of neotherosclerosis connect specifically to very late stent thrombosis, or VLST? That's when a clot forms in the stent years later,
Right,
right?
exactly. OCT has really clarified the etiology, the cause of VLST, which can occur months or even years after the initial stent implantation. While acute stent thrombosis happening right away, or subacute in the first month, is usually related to mechanical issues like stent underexpansion or edge dissection.
Right, the things OCT helps fix up front.
Yes, but VLST, happening much later, frequently harbors this neotherosclerosis. OCP studies show that neotherosclerosis is actually present in approximately 30% of VLST cases. So plaque developing inside the stent is a major mechanism driving these dangerous late clotting events.
Okay, if we kind of zoom out from all these specific biological findings, erosion, healed plaque, neotherosclerosis, the cumulative impact seems to support a powerful conceptual framework that the authors mention, the idea of panvascular inflammation.
Yes, that's a really important unifying concept that emerges from the OCT data.
What does panvascular inflammation mean in the context of something like ACS, an acute heart attack?
It means that ACS is likely not just a localized problem with a single culprit lesion that suddenly went bad. It's more likely a manifestation of a systemic body-wide inflammatory process affecting the entire coronary tree and possibly other vascular beds too.
So the whole system is hot.
In a way, yes. The sources note findings that support this. For example, non-culprit plaques, the ones that didn't cause the acute event in patients having an ACS, generally showed more vulnerable features like TCFA compared to plaques in patients with stable angina.
Okay.
Furthermore, in patients whose culprit lesion clearly ruptured, about 26% of them also had evidence of rupture happening simultaneously in other non-culprit lesions elsewhere in their coronary arteries.
Wow, multiple ruptures at once.
Right. This strongly underscores the idea that the underlying disease process is systemic and inflammatory, a panvascular process, which then leads to local manifestations, like the culprit lesion causing the heart attack. And the implication is that treatment and prevention really need to be patient-focused, systemically focused, not just zeroed in on fixing the single plaque that caused the immediate problem.
Okay, so we've clearly established the benefits of OCT. The amazing optical biopsy detail, the better guidance for PCI, these incredible new biological insights. Given all of this, what are the remaining barriers? Why isn't OCT just universally adopted in every single cath lab across the globe right now?
That's the key question for the future. The primary challenge, honestly, still remains the subjective nature of interpreting the images. They are incredibly detailed, yes, but also complex. Reading them accurately and consistently requires significant training and experience. This can lead to variability between different operators, different centers.
So the learning curve is steep.
It is. And then there are still some procedural limitations we touched on. You still need to transiently clear the blood with that saline flush, which adds a step and some complexity. It can also be difficult to image certain anatomical locations well, like lesions right at the very beginning, the ostium of coronary artery.
Right.
And that lack of deep penetration we discussed means you still can't fully evaluate the entire vessel wall thickness in larger vessels. IVUS still has an edge there.
So the immediate future isn't just about making the hardware slightly better, but maybe bringing in artificial intelligence, AI, to help tackle that subjective human interpretation problem.
AI is absolutely seen as the most promising solution for achieving more objective diagnosis and more consistent results with OCT. It's a huge focus of research right now. Researchers are heavily invested in developing deep learning models. These are AI algorithms designed specifically to mimic the subtle, learned expertise of highly experienced human OCT readers.
How do they work?
The sources specifically highlight the use of something called transformer-based deep learning models. These are particularly adept because they don't just analyze a single static image frame in isolation. Instead, they look at the context of adjacent frames, the sequence, exactly how cardiologists naturally reads an OCT pullback as they pull the catheter through the artery. They learn the patterns in sequence.
And how accurate are these AI models becoming? Can they really match an expert human in detecting these subtle, critical features?
They're showing remarkable accuracy already, and in some cases, potentially even exceeding the average human performance for specific tasks. For instance, the review mentions that for the difficult task of diagnosing plaque erosion accurately, one of these transformer-based deep learning models achieved an excellent C-statistic of 0.94. That shows significant improvement over older, simpler algorithmic models.
Wow. That level of machine accuracy really suggests that AI could eventually democratize this technology, couldn't it? Making expert-level OCT diagnosis available to potentially every cardiologist, regardless of their individual training volume or experience level.
That is absolutely the ultimate goal: wider access to expert-level interpretation. And we're already seeing the beginnings of this being implemented. The latest commercial OCT consoles coming out now are already incorporating AI algorithms for certain tasks. For example, automatically delineating calcification, outlining the calcium deposits, and instantly displaying the angle and thickness for the operator in real time on the screen takes the guesswork out.
That's useful.
Very. And the next phase of AI research in OCT will likely move beyond just diagnosis to developing prediction models, using all the rich data in the OCT images to predict a specific patient's likelihood of future clinical outcomes, like restenosis or stent failure.
Okay, so AI handles the interpretation.
Mhm.
The other major direction for the future is overcoming those procedural limitations through hardware advancements. Specifically, you mentioned developing hybrid systems and also micro-OCT. Let's start with hybrid.
Right. The hybrid approach comes from recognizing that OCT and IVUS are really complementary technologies, not just competitors. They each have strengths and weaknesses.
Right, OCT for fine detail near the lumen, IVUS for deeper penetration and seeing the whole vessel size.
Exactly. So the logical step is to try and combine both modalities into a single catheter. Get the best of both worlds in one pass. Research is intensely focused on these combined OCT IVUS catheters. The review mentions examples like the Novasight hybrid system and the dural sensor IVUS OCT.
What's the promise there? Just efficiency.
Efficiency is part of it, doing one pullback instead of potentially two, but also getting perfectly co-registered data, knowing exactly which high-resolution OCT surface feature corresponds to which deeper IVUS structure. That promises a much more complete picture of the plaque and vessel.
Makes sense. What are the main engineering challenges in making a good hybrid catheter work?
It's tricky. The main challenge is minimizing the catheter size. You have to fit two different imaging systems onto one tiny tip while also achieving really accurate co-registration. You need to precisely align the image generated by the deep penetrating IVUS sensor with the image from the high-resolution OCT sensor in space and time. Different manufacturers are tackling this in different ways. Some place the sensors physically overlapping for potentially perfect spatial alignment, but that might limit pullback speed or length. Others place them side by side, which might allow faster, longer pullbacks, but makes the data fusion and co-registration more complex computationally. So miniaturization and sophisticated data fusion algorithms remain complex technical hurdles they're actively working on.
Okay. And finally, let's look at the ultimate frontier for resolution. Micro-OCT or MOCT, what is that?
MOCT represents the next potential quantum leap in resolution, really pushing the boundaries of what might be possible to see in vivo. It achieves this, technically, by using a shorter wavelength of light, down around 800 nanometers compared to the standard 1300 millimeters for current OCT. This shorter wavelength allows it to provide extremely high resolution, potentially down to 1 to 3 micrometers.
1 to 3 micrometers. That sounds like actual cellular level detail, like true pathology, but in a living patient. Could this potentially replace the need for even taking a tissue biopsy someday?
That is absolutely the long-term hope and vision for MOCT. Achieving 1 to 3 micrometer resolution might, for example, allow for a definitive diagnosis of plaque erosion simply by visualizing the presence or absence of the single layer of endothelial cells covering the plaque surface. No more extrapolation, just seeing the cells.
Incredible. But there must be limitations currently.
There are significant limitations right now. MOCT is currently limited by the very same issue that plagued early TD-OCT. Physics dictates that the shorter wavelength, while giving higher resolution, also results in much shallower tissue penetration, even less than standard OCT.
Ah, so an even more extreme trade-off between resolution and depth.
Exactly. And currently, it also suffers from a relatively slow image acquisition rate compared to modern FD-OCT. So because of these unresolved speed and depth issues, MOCT has not yet been tested in humans inside coronary arteries. But it definitely represents the long-term technological goal, ultimate resolution in vivo. Hashtag tag outro.
Well, we have definitely completed a comprehensive journey today. We've tracked cardiac OCT literally from being this massive, unstable prototype in an MIT lab.
Yeah, needing engineers flying around the world with spare parts.
Exactly. All the way to its status today as really an indispensable modern tool in cardiology. And its impact is truly dual, isn't it? On one hand, it directly optimizes complex stenting procedures through precise quantitative guidance, leading to better mechanical results.
Right, better stent expansion, fewer complications.
And on the other hand, it acts like this vascular biologist microscope inside the body, revealing the true dynamic mechanisms of disease, things like plaque erosion, healed plaque, neotherosclerosis that we just couldn't appreciate fully before.
And if we connect this massive synthesis back to you, the listener, OCT provides the kind of knowledge that allows us, as clinicians and researchers, to move beyond simply treating a blockage. It helps us understand the underlying disease as a systemic problem, confirming concepts like ACS being a panvascular process, like we discussed. The technology gives us a much deeper, more accurate diagnostic foundation, which is essential for moving towards more personalized medicine.
Yeah, the key takeaway for me is just how rapidly this technology is still accelerating. The integration of AI promises to solve the interpretation bottleneck.
Making it more objective and accessible.
And the development of multimodality catheters, the hybrid systems, promises to overcome some of the current procedural limitations by combining strengths. OCT seems set to become even more pervasive and even more powerful in the coming years.
Which raises a really powerful final question, maybe a provocative thought for you to mull over after this deep dive. If these future AI-enhanced OCT systems become precise enough to diagnose a patient's exact risk profile, maybe identifying early, subtle plaque erosion with extremely high certainty, for instance, could preventative non-interventional therapies become the standard of care for certain conditions?
You mean shifting the focus away from mechanical intervention, away from stents, towards more predictive, personalized drug therapy based on these incredibly detailed images?
Exactly. Could the future of PCI, in some cases, be preventing the need for it entirely by catching and treating the riskiest features much earlier with targeted medical therapy? It's something to think about.
A fascinating thought to end on. Thank you for watching The Funnel Effect.